community than generally white LGBTQ individuals. That said, there is more to this discussion, and I'm hoping the part of what's happened since the pandemic is actually revealing that there are more and other things in addition to the things we talk about the most. So with that said, I'll turn to our panelists and our open question for everyone of what you think some of the biggest health problems are facing Latinx LGBTQ individuals.
Sorry.
Okay. Look, a little bit of numbers in terms of the U.S. population. There's 62.5 million Latinos. Of that, 62.5, 11.3 identify as LGBTQ. So 65% of those are identified are under 35. But what we're seeing in overall the Latino community is what we've been seeing over the years. With COVID, it did exacerbate heart disease, cancers, high blood pressure, diabetes also increased significantly in the last probably year and a half, as well as HIV and STI infections.
Let me follow up. How about what you see in your community, since you are in what the grassroots organization?
We see significantly, because we work with a lot of communities of color. We don't do regular health screenings, so a lot is already a significant diagnosis. So you don't see, you automatically see high blood pressure. But there isn't any where we don't have a lot of preventive education, where we don't go to the doctor that frequently enough to have those preventive discussions, either with a professional or at home. So unfortunately, some of those conversations when you go to the doctor is already, a diagnosis.
Okay, so first and foremost, I want to address something that everybody needs to know. Health is a human right, correct? I want to make sure that we are on the same page on that. So, you were saying is correct. We are an active environment, so we don't do prevention. We respond to issues, and I think this is one of the things that hurt a lot of Latinos. Also, talking about visibility, we don't have that many doctors in the U.S. that are bilingual, and so that's a language light that's not enough. So those are the things that I see that continues to increase in lack of services. We talked about earlier about even is as transportation, going to the doctor, can be a barrier of health. So we have to be very mindful of how to address things more holistically. So in order to address, Latinos healthcare in general. Now, unfortunately, the pandemic has done a lot of things, especially in the HIV community. The number of cases of HIV had increased among Latinos, while whites are being stable, even lower in some cases. But what is most important is the number of STIs have gone 300, 400% in certain areas. So it's something that also we need to address as well. And most importantly, the stigma. I think stigma is an issue that creates the biggest barrier of HIV. For example, when you have your grandma or your aunt going to the doctor, unfortunately they have diabetes or cancer, the whole family comes to help, correct? But doesn't happen the same thing for HIV.
So I would thank you. I think thank you for having me join and be with Eric, whom I work with closely.
My boss. Full secretary.
Full disclosure. But I've known him for about 10 years. It's very supportive. So being Latino or being LGBTQ plus. So that's, I think, the first lens, right? So Latinos on a population basis in the U.S. actually have longer life expectancy than whites. And the pandemic did knock off a couple of years of life expectancy, at least for the data for 2020, 2021. But I kind of think we're going to recover that because the death rates are now the same. And so we'll be back to where we were probably, or closer to where we were in another year or two. But why do Latinos live long when we're poor? And we have all these other social determinants that are not as good. We don't know. That's one of the things we research. We have this, people say, well, it's immigrants because immigrants are healthier. And that's generally true compared to people who've been here. But now 70% of Latinos living in this country are not immigrants. They were born. I'm originally from Cuba, but I came as a child. So it's a different perspective. You came as an 8-year-old and you come as a 30-year-old, and it just affects you differently. But when you look at the leading causes of death in this country, heart disease, stroke, and cancer, Latinos have 30% less deaths from each of these things overall. Doesn't mean that some areas or some populations will be worse. When we compare the Latino national origin groups, much of this benefit appears to come from people from Mexico and Central America. Less knowledge about Central America compared to, let's say, Puerto Ricans. Although when you say, oh, the Puerto Ricans do worse, yeah, but they're still better than the whites. They're white non-Puerto Rican. No, so I think that's an area that we haven't really understood, and we call it the paradox, because everything else should point, well, Latinos make less money, they have less education, they have much less access to health care, but yet they do better in this country. And data from Latin America for the big countries supports that. So you look at the death rates from cancer, heart disease, and stroke in Mexico, Argentina, Brazil, and certain other countries that have good data. I think Peru is on that list too. It's lower than it is in the United States, or certainly not higher than you see for U.S. whites. On the LGBTQ plus perspective, that intersection, we just don't know that as much because we don't ask, we don't know. And it's only the last, I would say, 5 years that we've talked about systematically asking these questions every time we do a study. And people, earlier with Dr. Hernandez said she was talking to the elderly. There was this thing mentioned in one of the surveys that we work with. We can't ask those questions about sexual and orientation or gender identity to our older participants in this big study because they're just going to say, oh no, they're turning me on. But when they tried, nothing happened. People were fine. And, there's always going to be someone who's going to not like being asked a question about your sexual orientation or how far did you go in school or how much, whatever. Because clinicians ask kind of probing questions like that all the time. And so that, I think that's a big, you mentioned stigma, that's a huge one. It's especially worse with HIV, but not exclusively. It also exists with cancer, with other things. And the biggest challenge is lack of health insurance. It's almost 30% of Latinos 18 to 64 have any kind of health insurance. And everybody says, well, it's because they're undocumented. No, it's kind of employment they have. And except for very few places that include, some sort of health coverage, no matter what you're working in, like New York City is doing that now. DC has a program. San Francisco has a program. If you work in certain employments, you don't get health care coverage. That's just the way it is. And that's the majority of it. And then the last thing I'll say is diabetes, for example, is a condition that is twice as common in Latinos as it is in whites. And it's not the Mexican Americans only because of indigenous background. It's also Puerto Ricans and almost similarly the Cubans and what we know about other groups the same. It's just there's more diabetes. Again, that's a scientific question. Why is that? Everybody thinks, well, it's everyone's increased weight. Well, that could be part of it. The kind of food we eat, maybe that's another part of it. Lack of physical activity. These are the things that we talk about as possible contributors to this. But it's most consistently true, probably the single most important chronic disease that is in excess among Latinos.
So thank you for the nice segue, actually, to my next question. So, by way of providing backgrounds, it was similar to Juan Rangel from the first session. I'm from Central California, and Fresno specifically, and the county itself is the most agriculturally productive county in the country, and majority Latino, and it has been that way for a number of years now. So the job that most people have, at least across the county, is agriculture, and agriculture doesn't necessarily provide health insurance or actually provide a healthy employment equally. I think there are certain price sections of agriculture that are more safer occupationally health-wise than others. But that said, getting to the next question, what is the current status of healthcare accessibility and quality for our communities? Edwin, you want to start this?
Sure. So there are two different things though. Is the access to care and the barriers to care. And then sometimes they intertwine with each other. For example, in California, there was a law done by LULAC that people, undocumented people, have access to medical if they qualify based on income, right? And then there is now a new law that was enacted this year that if you are over 50, also you are documented, you can get access to care. But there is still other barriers that we see that happen, like I mentioned earlier, transportation, the language, some other barriers. And to be honest with you, don't take yourself into your families. When your mom doesn't really go to the doctor, right? So, or they wait until they're sick already to even go to the doctor. And some of us also have this idea that you're gonna go to the doctor, they get sick or something like that. So they have so there's so many stereotypes as well that we have to be mindful and we have to educate about the abilities. I feel that that we need to be more informative, and we also have to be more strategic in how to address these issues. But unfortunately, too, in other states, like for example, Texas, they don't have a road act, so you have issues having insurance, and it's really sad. As America's constituents, we should also reach out to our officials to change those laws. Like it happens in California. So I feel that as long as it earlier was said, with progress comes backlash. Every time we try to do something good, something better, so somebody's going to have to come back and say, why are you doing this for, right? But I believe that as human beings, we should care for each other. And I think that would be the best solution to eradicate this issue, which is huge. One thing that you mentioned about the ID is that always calls to our doctors is at the Healthcare Foundation. We have several clinics all over the U.S. Is that when it goes to HIV care, if the person is adhered to that care, they can live a perfect life. The issue is diabetes. They'll just at HF have so much issues with diabetes, like that HIV is perfectly fine, but not diabetes. So even HIV now has a higher way to be controlled in diabetes.
To piggyback off of what Edwin just said, where we don't go to the doctor at all, or there's culturally, we, like in Latin America, not a lot of people have access to medical care. So when you come here, that kind of remains the same. Fortunately, there are some regions like, and it's going to vary state by state, like DC specifically, there's insurance based on income, regardless of your legal status. Some people are still afraid to take advantage of it because, of a possible of it affecting your application or your status a status change down the road. With things. Sorry, could you repeat the question?
What's the current status of healthcare accessibility and quality for our communities? And how do you see it where you're at?
Where I'm at, unfortunately, it's going to be, I guess, outside of, like, like you mentioned, in many states, it's going to be based on whether you're documented or not, which is the sad truth. If you're fortunate to be documented, you can apply for assistance or just pay for it yourself. There are some states that will allow you to pay for coverage, even if you're undocumented, but that's not every state. So it's going to be very, even regionally, like with Maryland and DC and Virginia, there's, they can be black and white, just moving from state line.
Right. So I think focusing on access and then quality are two big different ways of looking at it, right? So the first thing with access is having insurance. We already said Latinos actually are the group in the U.S. with the highest rate of uninsured, and this is 18 to 64. All children get insurance, so children should not be uninsured. The 1% that aren't is because they haven't done the paperwork. But there's a program called CHIP. It's a federal program, so every state provides insurance for children. And then if you make it to 65, most people, not all, are eligible for Medicare. And so there your uninsured rates go down very dramatically. So it's the working people between 18 and 64 that have the biggest problem. And that's where the 30% uninsured are. Documented or undocumented, it's all mostly driven by type of job. The really poor get on Medicaid. But most of the people I'm talking about are not that poor. They're above, they're 150% of poverty. They're making, $35,000 a year. So they're not eligible for Medicaid in most places. Expanded Medicaid, yes. So when the states expand Medicaid, you can go up to 140% of poverty. So it's up to about $40,000 a year household income. Then the next question is quality. So once you get in the door, is there anyone there who's going to kind of have any sense of know how to communicate? But I think someone mentioned language.
Yes.
Yeah. So for the monolingual Spanish speaker, having some clinician who speaks Spanish is a big advantage, and that's just not always going to be available. And for just the communication style, how culturally sensitive are the clinicians? And this is where a lot of times the community clinic concept, your organization runs a bunch of clinics focused on HIV care. Well, the federal government has the FQHC, the Federal Qualified Health Centers, and they were established with the idea of their community asset. They're going to take care of that community that they're in, and many times have had a race ethnic, although not always, depending on the location. For example, here in D.C., I'm familiar with, people may be familiar with Unity as a very robust network of community clinics, depending on where the one in Columbia Heights is very focused on both the Latino and African-American community. There's also a Clínica del Pueblo, which is a smaller operation that operates in Columbia Heights and also in Eliseo. So you can get primary care. May vary sometimes, but you can get primary care. Get in the door, see someone who can treat your initial issues, manage your chronic diseases. But if you get a bad disease that needs a specialist, or if you need a procedure, that's where you start going through hoops if you don't have insurance. So if you mentioned this, if you cross state lines, so if you're in Hyattsville and you have a diagnosis of cancer and you need to see a specialist, the primary care clinician has to go around begging whatever oncologist is around, usually some Catholic Charities or some other organization, to be able to get their patient seen. Or send it to NIH. Sometimes we can find a protocol at NIH that will fit that cancer, and that can work. You can go on down the list. Oh, I need a consult from a specialist for, cardiologists usually get, or gynecology or care for pregnant women and children, but not not first all specialty.
For primary, like you have like pay scales, and also for like our center has pay scale for HIV care, but when it comes to specialists, like mentioned, that's where you don't see the pay scale programs.
Yeah. I mean, it's sliding scale.
Yeah, more like scale. So then it's unfortunately full price.
Yeah. And then if you have no insurance, right, they charge you full price, which is. And then there's a whole thing about. I mean, I don't know these days. You know, like Eric said, I practiced medicine for 37 years in San Francisco. That's where sort of grew up clinically. You know, I was there during the beginning of the AIDS epidemic. You know, I came from Miami. I went to San Francisco. I mean, as a professional doctor, as a clinician, and especially primary care, you know, your training is, you know, you're open to anybody, whoever comes in, what they do, what they don't do. Yeah, you ask and treat people with respect. You ask for respect back, and that's about. And whether that's universally the case or LGBTQ plus individuals going somewhere for care outside of certain areas, I don't know. I haven't been in those areas. So people would have to sort of talk about that to see how they would feel in that context. And the same could be true for Latino, for it shows up in a place that was very used to a different kind of patient, being Latino, just independent of anything else, already feeling like, am I in the right place? No one looks like me. I mean, this is strange, and feeling like you don't belong there. And then that makes it hard to feel like you're going to get good quality because you're not perceiving welcoming environment.
So thank you for those answers. I think there's a number of us could probably speak to individual experiences. I know some here, like up in DMV, related to having more difficulties with certain clinical providers, certain clinicians, in certain medical systems versus others, and having to share information with each other of like, oh, who do you go to? Where do you go? Because I had much better experience here than there, etc. So moving on, we'll start with you. And so, how has NIH overall responded to the health disparities that have been highlighted by the pandemic, particularly as they relate to our communities?
Well, you're familiar with this, but I first of all, I would say that, you know, I don't know, thinking back 2.5 years ago, March of 2020, when this all started, you know, from my perspective, as those first couple of months evolved, you know, I now can acknowledge how scared I was. I said, what was going on out there? As the world, you know, what's happening? You know, people are, those first reports coming out of New York City, in the U.S. and Millan, that were really alarming. And you know, this is a virus that's going to just spread around, and people just going to be dropping dead. You know, it's almost felt like that kind of that kind of tragedy. Also, at the beginning, it became evident that the Latino and African American communities, and American Indian and Alaska Native communities were disproportionately impacted by this pandemic. With the Black and Latino community was clearly the kind of job and kind of communities people live in, and how dense people were crowded. So you couldn't telework if you were working construction, right? You couldn't telework if you were at domestic work. And so the kind of employment was really number one. And the second was, sometimes there's two families in one household. How are you going to self-isolate if you're exposed when there's one bathroom for 8 people? Yeah, you just can't do it. And the expectation was that, those were the advice we were giving. So we saw those rates just skyrocket. The good thing about the community on this is that as of this year, a couple months ago, the death rates across Latinos, African Americans, and whites are not different. And it's mostly because we have got most of the communities have similar rates of at least 3 doses of the vaccine. And so the success of that, which if it holds, let's gotta wait and see if these things hold. We don't know what's going to come this winter, although, it already is looking, like I said, the triple threat of 3 viruses coming. But at least we're starting off from having achieved something that wouldn't have been possible without all of you doing your part, whether you got the vaccine or not. I mean, people just advocating for health, advocating for the right thing to do. The professional community really stepped up in really having some trust in science that we were looking for, the answer, how to manage this from a scientific side. Developing a vaccine, developing a treatment. Yes, masks work, even if they're really annoying. And you can't understand anybody who's talking and trying to talk to you through a mask very well. And so I think that's, but it did shine a light, so to speak, on these disparities in an unprecedented way, and it led to NIH doing a lot more for disparities research than it had ever done up until, what we did in 2020, nothing like that had happened before in a single year. I can say that with certainty.
Yeah. Well, I believe that AHL was put in a position and to utilize the same framework that we utilized with the HIV base. Back in the 90s when we got that cocktail. So we're very strategic in how to address this because our patients already have a weakening immune system, having HIV/AIDS. So the way we strategize it is that we cannot close up clinics. We have to be open. And we also put a lot of effort into our employees too, because we run 54 clinics in the U.S., but we also have over 750 clinics in the world. So how can we have our employees safe too? But this is what I think. This is what the president of that organization stated: is that we chose to be in this area, we chose to work in this field, right? So we are compassionate human beings, so we have to tackle. And you don't feel comfortable, well, you have to look for the non-career. You have to be honest, and unapologetic. You're here to provide service to another human being. You have to be productive at 100%. So we utilize that approach. Of course, some people didn't realize that, but we did a great job. One thing that the company did also is because people working from home, we started telemedicine. In some instances, and our clients have to come and get network data every 3, 4, 5 months, depending on the difficulty, at least on not just HIV but other diseases that they have or any other conditions. But at the end, I think that the approach that it's being used, it can be repeated like everywhere else, and sometimes we tend to forget those things. We like, we need to rewrite the wheel again. So we tend to forget that. So we have so many frameworks and so many best practices that we already have, that is just to the fact to putting into place and make it work, right?
Yeah. So, since we do more day-to-day patient services, I think with a lot of other community-based organizations, it was like an overnight of educating yourself to educate the community and the specifically our patients on how to live in the state of COVID and all of the stages that were continuously changing. I can tell you that we went from working at home and then eventually transitioning back to in office. But while in the beginning stages, it was it I can tell you that it forced many organizations to move into telemedicine, which is something that we hesitated a lot, but we see the benefit of it. There was a lot of the use of language lines, a lot of community health workers, and got involved in terms of providing support to the medical staff, doing a lot of translation, because one of the things with the language access fund is that it's a very formal Spanish, where a lot of the population might not who has a limited education, they might not understand the Spanish that's being spoken to them. So it's getting someone who, like for instance, I still do this. If a patient requests me to go in with them for their ID care appointment, I'll translate for them and break it down to vocabulary that they're able to better understand, as well as they're able to express their needs, more clear to the doctor. As far as our organization, through some of the COVID funding, it was providing kids with masks, disinfectant, the face shields, basic needs that they needed, connecting them to food banks, dropping off food bank orders to those who didn't have access to transportation. So a lot of footwork to help those in need, to make sure that they're off of their medications were being delivered on time.
Something that I want to add also, which was crucial in this fight, it was the partnership with other agencies throughout the U.S. It was great. Then I want to mention LULAC as well, because for example, in Chicago, what we did is Calor, which is an affiliate of AHF, partnered with LULAC. So AHF was doing HIV testing, STIs, and LULAC was doing the portion to a contracted commercialization of the testing for COVID-19. So, having this partnership and be very strategic how to address different demographics. AHF has the ability to be very strategic when it comes to different demographics. So, for example, at AHF, we have a Latino division, which I'm the president of, but we also have a Black division. We also have a trans division. We have a women's division, and we have a gay men division. So we were very strategic on how to utilize all affinity groups to promote, self-care and promote, care. Talk about, the difficult part of, asking people to get vaccinated, for example. That helped quite a bit.
So thank you again for a very nice easy segue into my next question, particularly about the LULAC councils. What would your recommendations or suggestions be to community groups such as our councils across the country in order to reduce health disparities that we've been talking about just in our community?
I would ask to volunteer maybe at least once a month at a local clinic. You do not understand the need of interpretation and to have to speak your language, and how easy that becomes, and it becomes life-changing for these people, because if there isn't someone who speaks your language or someone that looks like you, you're probably going to turn away and continue looking for services up and down the roads until you find someone who's able to help you. Just volunteering, showing up, being present, that definitely makes a difference in local care.
Actually, that's the good. Sorry, that's exactly what I would ask the same thing. I feel that in the area of healthcare among Latinos, there is not enough providers. There is not enough, psychologists, psychiatrists, and especially for our demographic that sometimes we don't have those specific needs. But also, besides just volunteering at any clinic or our federal 5% would be that to be more involved, and also not just for us to invite you, but you to invite us, to see how can we collaborate together. Because I believe by unity, we can accomplish more.
So I was thinking of the organization, not what individuals could do. So by your point about volunteers, I think it's a really important one. But advocate for access. So LULAC more explicitly advocated for, addressing the uninsured issue in the U.S., which disproportionately impacts Latinos. Really keep, up the discussions about discrimination and racism. I think the prior session, when I caught of it, is really critical. I had the opportunity to spend a little time talking to a historian, Eliseo, right? Is his first name Kendi, who is in Boston University, and he has a book called How to Be an Anti-Racist. And if you're either racist or anti-racist, there's no in between. And then some people are often both, and there's nothing, there's nothing contradictory about that. That's the nature of our society. And this conversation about how Latinas, how our communities in Latin America have been, racism is there, and begin to. This is really, I think, a cross-cutting relevance. You mentioned the diversity in the workforce, but if you look at physicians, only about 7% of graduating physicians today are Latinos, and this is with almost 20% of the population. So there's a huge gap that we're not going to make up anytime soon. Oh, we do better with nurses. No, we don't. We actually do worse. With pharmacists, we do worse. So there's a problem, and I think language is one of them. But when you look at what is 7% of physicians, and including African Americans, add the African Americans, another 7%, they disproportionately take care of the poor people on Medicaid, people who are uninsured, people who don't speak English. So and we have legal barriers. And, affirmative action is not going to continue, most likely. So we have to find other ways to get it. And then the last thing I would, and I mentioned language and immigrant issues, is to think of the highest risk conditions. So HIV is a great example, right? It's a disease that, everyone was eventually going to get really sick and or die when I first saw it. Those first 10 years plus of HIV was, that's what it was. Now it's a disease that you take one pill a day, most of the time you can control. As long as we don't do anything stupid, like people take different pills, different times, and you develop resistance. People still die, people still get complications, but we know what to do with HIV. Much less about diabetes, much less about heart disease or controlling blood pressure. We know what to do there. We know what pills to give it. People have to take them. And to lower the blood pressure to keep people from getting stroke. So I think that focusing on the highest risk conditions where we can often do things to make a difference, I think is the most valuable investment that we.
Thank you for all of your insights. We have about 7 minutes right now. If it would take maybe 2 questions from the audience.
Oh, wow.
Sure, in the back of them, so.
Okay. Because I feel like between parts of the ministry, how read about do you think it's mental health and drug use on current to all populations, and if possible, like what's the approach of being you?
Yeah, I would add substance is
Sorry, he said I'll start with this one. I had been meant to mention it, so thank you for asking. The pandemic has clearly precipitated a new wave of increased use of substances, particularly at alcohol, as well as non-opioid drugs. We saw overdoses go up again. And now, 10 years ago, Latinos and Blacks were actually better off on overdose. Guess what? We've caught up, and in the case of African Americans, they've passed. The highest rates of overdose are among African Americans. Mental health issues, the major mental health disorders, the things that we call severe mental health illnesses, schizophrenia, psychosis, severe bipolar, are most likely driven by genetics, and so they happen in similar rates across most population groups. It's a matter of recognizing it and treating it, and there are treatments for all of these. No cures, but treatment, management. And then things like depression and anxiety are more common and happens in every. So, wrap up. Yes.
I want to respond in that area of substance abuse. So we have noticed that it happens also a lot on gay males. So what AHF is doing is promoting having a campaign on prevention and harm reduction. So as of now, if you go to an HIV pharmacy, if you ask for strips to test fentanyl, you can get those for free. Also, we are promoting going to neighborhoods and community events with our pharmacists to educate people how to use nose, also Narcan as well. So, but something that is very important, and I forgot to talk about this, is about the nature of the lack of providers, correct?
Yes.
And what I see, because a lot of my friends are doctors, and there are some of them that are burnt out, right? And so I think we need to create policies to have more Latinos become doctors and nurses and things like that. And then there's some cities, some areas that have this no forgiveness, because when you become a doctor and you want to be HIV, you're not going to make a lot of money, correct? Right. So in some areas, and I hope this happens more often, is that you work in an area that is low income and privileged, or you work with a privileged community, you get they give you or they forgive you all that for the loans that you have taken. So I think that there will be a good way of incentivize people to become doctors and nurses in those areas. But that's much more of a policy issue that needs to be addressed, that we need to work collectively to address it.
I was thinking, in terms of what we see a lot is depression. 30% of LGBT, especially LGBT youth, are diagnosed with clinical depression. So a lot of professionals, case managers, social workers, are being prepared to ask, to have screeners ask questions, more in-depth questions, if need be, going into suicide, substance use, and programs to refer those who need them. Our agency specifically, like HNF, we have a substance use kit with where we train people on how to use Narcan properly. The fentanyl strips is also good, and it's available to anyone. Like a lot of what we've seen with the COVID is a lot of drug overdose, especially with fentanyl. So a lot of CTOs or community-based organizations are offering that. I believe even at a CVS here in DC, you can stop in and ask for Narcan for free.
So, question. Yeah, so in this session, we need issues in the healthcare condition that affecting car condition. Is there any specific issue that you feel that you're overlooking, like retardation? I feel like every day needs our attention, and your company is in your attention. So we're overlooked.
I would say, as professionals or as patients, asking for regular screenings when we go to the doctor. A lot of the doctors don't offer screenings just because of lack of time. So ask for whatever medical screening you need at whatever age range you are, just to keep do preventive care instead of terminal care.
Yeah, I would agree. I think that would be a great solution. For example, sometimes people that are diagnosed with HIV, they're diagnosed at a hospital. And of course, the medications, they do well after even 2-3 months. But having that out as a nationwide thing to, test for HIV, that this is not as expensive, because I know that, medicine issue, wherever you go, but I think that would be a good preventive way to address something that I think we're lacking of.
I would say the idea of a primary care clinician being a coordinator, if you wish, of care, we that has a natural common sense to it, and actually there's good evidence that works and it saves lives. But yet in our healthcare system, we haven't really valued that. It's always the specialist with the most training or the technical part that gets rewarded. And it's really the reverse of where we should be. We should have a very solid foundation and trust in that primary care. It's hard to get there because we haven't ever really created the conditions for it to happen.
So it sounds like on an individual level and community level, it's kind of having those conversations, and with our family and for ourselves, it's like, I'm at this age, what should I be doing? How often should I be doing it? And same thing for my family. They're at these ages, what should they be doing? How often they should be doing it? Because catching this stuff early means it could be surgically treated or medically treated in other ways more quickly, more easily, more cheaply than what, like I mentioned, terminal care, which is kind of like the worst case scenario. So thank you, everyone. Thank you for the panel. I
really thank you all for coming to today's summit. And the panelists, thank you so much for sharing all the wonderful insight. I like the call to action to start volunteering at health centers and to be those advocates for increased health care funding for the living people, really for all communities, because like you said, healthcare is a human right, and we need to start electing and supporting our leaders who believe that. So thank you again for the wonderful insight. I'm so honored to have all y'all's presence here. And now, before we leave, I want greetings. A reminder that we're eating 7 tonight at Disparities. And you're welcome to come. Second, I want to thank our sponsors today, DC Library, for hosting us. This is for fast families all plus our libraries that provide free space for organizations like ours so we could have this exchange of ideas. They've been attacked by the right wing, have their books banned, but they're still here providing a great service to the community. Support your libraries back at home. Second, I want to remind the folks that are LULAC leaders or people that want to form LULAC councils in their area that we'll be meeting tomorrow between 10 and 2 at the National LULAC office at 1133 19th Street Northwest. You will be provided for food. I know it's very early, but you're going to get fed very, very well. And last but not least, we're going to have a little, if you're a LULAC member, paid LULAC member, please stay. We're not going to take the full hour. We just need some input from you before you leave. And last but not least, let's take a group photo in front of this thing. So if you could help me with the tape, I should. It would really mean a lot to me to have everyone in this room. It's a tradition that we have.